Today I'll discuss the case of a man around 40 years old who presented with thumb numbness and tingling as his primary complaint. He reported that about 2 months prior to our initial visit, he had been in the gym and did a shoulder press during which he felt something in his right shoulder and then his right thumb went numb. So it's important to note that he did not feel anything in his neck at that particular time. Then he woke up with a bad neck. His primary complaint is that right thumb having altered sensation. The medical term is paresthesia, so not normal sensation, which can include tingling, numbness, or both. In his history, and I ask about this for patients who present like this, where it seems like they're having symptoms in the extremity that are coming from the spine because primarily of the paresthesia. Paresthesia is not a symptom you would generally find if there were a shoulder injury to a structure in the shoulder, for example. But it is something we associate more with nerves, and where are nerves injured the most? In the spine, unless there is blunt trauma to a peripheral nerve, and there was no trauma to his thumb. So I did ask him, and there's a space on the sheet, do you have a prior history of spinal disorders? He said about a year ago he had some neck problems, but it went away, I surmise. So if we go back to this case, before meeting me, he had already been to the doctor, a primary care physician, and an orthopedist. He had had an MRI performed of his neck, which showed a herniated nucleus pulposus at C6, herniated disc at C6. Now, when you think of the C6 nerve root, for most people, and individual variation can occur, it is going to innervate, or that nerve is going to supply the sensation to kind of that outer aspect along the upper extremity into the lateral thumb. It can be a little bit different with other people, maybe a little bit more in the front, and it's not always a one-to-one kind of looking at the dermatome map and the person, but his was quite textbook. I encourage people, if you're having symptoms in the extremities, for example in the lower body, just look up lumbar dermatomes, low back dermatomes. If the trunk, thoracic or cervical dermatomes, in the upper extremities or head, cervical dermatomes. Dermatomes, derm meaning skin, area of the skin where the sensation is dictated or controlled by that particular nerve root from the spine. So if you're having symptoms in the shoulder blade area, you will see that can possibly be referred from a thoracic dermatome. If you're looking at the middle finger, for example, that can line up with a C7 issue, a nerve root C7 being irritated in the spine. It can give you a clue, especially if there's numbness and tingling present, that the problem might be emanating from a nerve root irritation in the spine. Again, in this scenario, and in many patients' scenarios, he is not coming in with neck complaints. He is coming in with primary thumb complaints. So the herniated disc on the MRI matches with his symptom presentation, and it matches with his sign presentation. So when I ask him kind of better and worse, it's not this like clear on-off switch. When I'm sitting, I'm worse. When I'm standing, I'm worse, etc. But he does say that he'll get that intermittent paresthesia in the right thumb several times a day, and it's very noticeable. Right now, he is someone who likes to work out, generally 5 times a week or so. He's avoiding that for now. No red flags. He had taken a Medrol pack that he was prescribed, and at that time that I saw him, he was taking meloxicam, but no other kind of major things to note in his history. But he will get some stuff in the arm as well as the thumb, but the thumb is kind of the primary complaint. It is not disturbing his sleep, but again, the better, worse questions, not that illustrative for him. So that's the verbal history, very short for this gentleman. The physical exam, again, in orthopedics, you gotta think 3 main buckets: joint mobility, muscle strength, and nerve tension. There's also muscle flexibility, there's also balance, there's also proprioception, there are other things. Those are the three main things. For most people, they're the things I focus on. And then we have functional baselines, or baselines that kind of play off of those, meaning if I sit, it hurts. If I hop on one foot, it hurts. Things that we can do in the clinic to use as physical exam baselines to help us gather our evidence when we do potentially cause and effect testing that is repeated movement testing. Other types of testing, which are distinct from repeated movement testing, are not going to usually show a cause and effect change within 2 minutes or 5 minutes or 10 minutes, right? A lot of tests that we learn clinically, like ligamentous tests, it's not like you do the ligament test and then you retest the physical exam baselines or the verbal history baselines. The ligamentous test is just going to tell you if that ligament is stable or structurally sound. Same with a lot of other things. They might tell you about the structural integrity of a muscle or another structure in the body, but they're not something you kind of go back and forth with vis-a-vis cause and effect testing. So I'm usually gathering a lot of these tests or functional baselines because they can provide so much importance with cause and effect testing for repeated movement testing specifically. Repeated movement testing, also known as the McKenzie method or MDT, mechanical diagnosis and therapy, is not used by many clinicians, unfortunately. It's not that widely or kind of thoroughly taught in academia, and so people like me, clinicians like myself, physical therapists, primary care physicians, athletic trainers, nurse practitioners, medical doctors, all of these types of clinicians can learn this by going to the courses after graduation, getting credentialed if they want to, meaning getting a kind of base level of knowledge and getting a diploma, which is something I did because I really believe that this test and learning how to do this test correctly is extremely important in the field of orthopedics. I think it's the most important test that we have. We also have MRI tests, X-ray tests, ligamentous tests, other tests. If you go into the history of the evidence of those tests, however, a lot of them are poor. There was a good textbook several years ago by Cook and Hegedus. They actually go through the evidence for these tests that we were taught in school in particular, and they show that the evidence for a lot of these things is flimsy. For example, tests that say, oh, if you push on the shoulder this way, you're testing the integrity of XYZ, like the labrum or the supraspinatus. They look to see if that evidence holds up, and for a lot of things it doesn't. And to fill that hole, so to speak, since there aren't clinical tests that are that useful, and we know that imaging tests have a time and a place, but they're not the gold standard, to fill that lack of good testing, that's where repeated movement testing comes in. It is just so important, and I find it's necessary for at least 80% of people with orthopedic disorders or orthopedic complaints. So physical exam, dural signs, so neurodynamics, nerve tension. He had mild tension on the right upper extremity. I did the nerve tension testing quickly in sitting, which is not the kind of gold standard way, and then I did it in supine. In terms of weakness, he had mild weakness in right shoulder external rotation. And then with the neck, there are 8 joint mobility tests that we look at. For him, protrusion was full, but it pulled on his neck. Flexion was full. Retraction, I put a minimal loss, although it's hard to really ascertain that, of course. Minimal loss with retraction, and it produced right upper trap symptoms. And then extension of the neck, I put as a minimal loss with deviation to the left. So that means when he extends, he goes a little bit to the side. And you gotta look for it because sometimes it is mild. It's usually, in my experience, away from the side of symptoms, which puts forward the idea that that disc on the right side, or that posterior side, a little bit biased to the right, is preventing that kind of space occupation of that disc. It's preventing the spine from moving normally into extension. It just can't go there because the disc is in the way, so to speak. And then the other 4 motions, bending right, bending left, rotating right, and rotating left, there was minimal loss and no loss for some of those, and they produced some slight pulling on the right neck. So that's what we're going off of. Now, I decided with this gentleman to use repeated movement testing. of his neck. I believe, based on the MRI and his report, that this is a neck problem producing that paresthesia into the upper extremity, primarily into the thumb. So we did 2 sets of 8 of seated retraction. And when he did it, it would produce right upper trap symptoms, but those symptoms were just fleeting, kind of like a light switch, and then they would go away. After those 16 or so, he had better right external rotation strength of the shoulder. His range of motion didn't look markedly different, so I moved on to another repeated test based on that lack of major change, and just went to retraction extension. We did about 3 sets of 8, so seated retraction extension over the chair. It also produced neck pain when he did it, but not worse. And when he did it, it would also kind of send an intermittent wave down his right upper extremity, to use his terms. But again, with repeated movement testing, I am notating what happens during the movement, so it's producing neck symptoms, and I'm noting what happens after. And afterwards, he's just sitting there, like, oh, I feel the same as before, right? You can use 3 options. This is a multiple choice test: worse, better, or about the same. And for me, I usually say the word worst first, just to try to discourage the patient from thinking that I'm leading them to saying I'm better. So after that, I noted that he had better better range of motion of his neck, and I like that to continue at home. Now, after repeated retraction, you could start adding overpressure, you could do retraction in supine, in prone. There's many different places a clinician can go. For this patient, and for a lot of patients, most of the problems are in the lower cervical spine. C6 is the second lowest vertebra in the cervical spine, the neck. C7 is the lowest. C7, for most people, if you touch the back of your neck, is the biggest bump at the base of your neck. So C6 sits just above that. Now, in order to really move C6, it's going to be some form of, it's going to be something other than retraction. Retraction is primarily an upper and mid-cervical movement, so it's not getting the lower neck to end range at all, and it's moving it mildly. So I wanted to see about getting the lower cervical spine to an end range position to test that. So that's why I went to retraction extension versus another sagittal plane movement. Now, yes, the symptoms are on the right, and this patient may need a right-sided movement. Those patients are in the minority. Most neck issues that are mechanical, that can be fixed with a specific movement, need something in the sagittal plane, usually in a retraction or extension or combo movement. Not all though, so maybe he will need a side movement, but it's not something I would go to on day 1 due to prevalence and due to the fact that he is showing some promising effects with this in terms of better strength of his shoulder and better range of motion. So his homework became seated neck retraction extension, about 10 every couple hours. Careful with posture. We talked about posture in terms of laptop and working from home. The second visit was exactly a week later. He was doing the sets about 8 times per day as instructed, and he said, when I say big picture, as a result of doing these exercises, and I usually say, and as a result of making the postural changes, if we made any, do you feel overall about the same, worse or better? And he said he feels about the same. He noted that he was paying more attention to his posture. So then I'm gonna go look at the physical exam after doing that verbal intake again on visit 2. And could I add more tests? Absolutely. In the physical exam for him, I didn't really add anything. I just went on what we had done before. So external rotation of his shoulder now was 5 out of 5. So full strength and external rotation of that right shoulder equal to the left. He felt, or the nerve tension test was a little bit better. And then I looked at the motions. I didn't bother looking at protrusion and flexion. In the interest of time, I'm often not gonna test things that aren't of high consequence or things that weren't positive before, weren't a problem before. So I looked at retraction, I wrote nil loss, but it produced right shoulder symptoms. That extension was still minimally deficient, but there was less deviation, I wrote down. And then the lateral motions, the biggest one that was stood out of the 4, side bending right, side bending left, rotating right, rotating left. Rotation to the right was mildly limited. And again, they were still pulling on that right side with rotating to the right and with side bending away. And that's often the case. That's a pattern we see, that if there are right-sided symptoms, side bending away will kind of provoke it, and rotating towards can provoke it too. I find that to be the strongest pattern, though clinicians might find other things and there might be other patterns. So I asked him, please show me how you did the exercise. His demonstration of the exercise was good. And then I decided let's just go to overpressure. So for almost all patients with spinal disorders in the neck that are mechanical in nature, we will need to add some overpressure to get the joint all the way to end range to get our final answer. Moving 50% of the way or moving 90% of the way might give you some clues, but you have to take the joint all the way to its end range. The expression we use is end range is where the magic happens, and it's absolutely true. I've had patients where I show them how to take their joint all the way, and they just don't, and they don't get better. And I say, well, you need to do this. You need to push the back higher or push the neck more. And if they don't, we're just not gonna see the positive results that we want. An example I show patients is, look, you gotta take the joint all the way to its end range. Like taking the finger into extension 75% of the way is not it. We gotta take it all the way. And when you take a joint all the way to end range, you will feel the strain of the surrounding tissues. That is normal, and that can help people understand if they've gone far enough. Of course, if you can't go any farther, that's also an indication that you've taken the joint to end range, but it's not gonna usually go unless you apply that overpressure. For example, I cannot get my finger to end range extension. I can go halfway, and then I gotta take it all the way like this. It's a big difference in the range of motion for some joints. It's a less significant change in other joints, but it's a change or a difference nonetheless. So we looked at retraction, extension with overpressure on the chin. I tend to use the overpressure on the chin versus the rotation, which is delineated in the Treat Your Own Neck book and the textbooks, because I find patients can do it better. And we're still getting to end range. So it would produce that mild wave in the upper extremity and the neck, not remaining worse after, so very temporary, like a light switch, increased range of motion with decreased pain into right rotation, I wrote, and possibly a decrease in tension, although it's ambiguous. When it's questionable, I say about the same. Then I decided to look at prone sustained retraction extension. We did 2 sets for 15 seconds and then 2 sets for 20 seconds. It would also produce some of those wavy symptoms into the upper extremity and the neck, but increased range of motion, better, tension, better. So I wanted him, when he could lie down on his stomach and do the prone version of sustained neck retraction extension, I encouraged that, but I also wanted some more retraction extension overpressure and sitting when he couldn't get on the floor. So I don't often kind of give the choice, but for this patient in this scenario, I did. So then I saw him a few days later. He had been doing 4 sets of each home exercise program, or each home exercise per day. Again, he felt about the same and a little bit more in the fingers than prior. So when we're hearing more distal symptoms or an increase in symptoms overall, we're starting to think, well, this is a worse presentation. So in my mind, I didn't want to stay with more extension because more in the fingers is not what we're looking for. Centralization is when symptoms that are emanating from nerve root irritation or structural irritation in the spine move towards the center. Peripheralization is when they start moving more peripheral. Now, he can't get more peripheral than his finger, but an increased frequency down there is a worse presentation. So I quickly did the physical exam, external rotation of the shoulder, still good, no nerve tension, and we just tested, again, looking for something that was provocative. I was like, can you do something that would produce any symptoms? We tried some push-ups, he did 5, there was no effect there. So we weren't gonna keep, reaching for things that would produce his symptoms, because in his daily life, it would just kind of come periodically. So I looked at extension, still a tiny bit of a loss in extension with mild deviation still to the left. It produced his right shoulder when he extended his neck. And then right rotation was better and side bending was better, but the right rotation still produced mild symptoms on the right. Again, show me the homework, he did it, it looked good. So I'm thinking I need to go to the side of the symptoms. So do a movement, a lateral movement to the right. Could you do rotation? Could you do side bending? Either one. However, if you learn the system of repeated movements, you know that most patients are going to respond to a side bending movement versus a rotation movement. So we looked at right side bending or right lateral flexion. We did 15 of those, and then I had him do a couple sets where he did overpressure. So he did a lot of them. It would produce arm similar to extension, kind of produce that wave of symptoms into the right upper extremity when he did it, but not worse afterwards. Also a question I'm always asking, the more we do this movement, do the symptoms get better when you do it, get worse when you could do it, stay the same? Meaning every time he bends right, whoo, I get that weird tingling down my arm. Now by number 10, is it the same? By number 20, is it the same? By number 30, is it the same? A decrease in symptoms with repetition is a good sign. An increase of symptoms with the more repetitions you do is a worsening sign. So for him, I wrote down decreased symptoms with repetition. That's a positive sign. After all of those, so he did about 10, 30, 40, 50 to 60 of those repetitions to the right, some with overpressure. He had increased neck extension with decreased pain and no deviation. So the deviation was now gone. Decreased pain with retraction and right rotation of his neck, significantly no production of symptoms on the right. So retraction with right side bending with overpressure becomes the new home program. I didn't mention retraction before, but before we do a side bend or rotation, we always mildly retract the neck. Think of it as kind of like stacking the joints because there is that mild lordosis in the neck. So you're kind of making it flat and then doing the procedure. Do you have to? No. If you get a better result by doing protrusion and rotation or full retraction and side bending, do that. You go where the signs and symptoms take you. However, especially if you're a patient who's trying to figure this out on his own, or you're a clinician who is just learning this, you want to probably go by the book because the book was written and created by a clinician, Robin McKenzie, who did this with over 30,000 patients. So because of his genius, he was figuring out, well, most people need to mildly retract and then side bend to get the best result. That doesn't mean that you can't do it differently. I've told patients this before. If doing a handstand every 2 hours makes your knee pain better and makes your signs better, then there is proof that I'm going to ask you to do a handstand every 2 hours to make your knee better. You're looking for cause and effect, and that cause and effect does not lie, but the clinician needs to know how to get a good physical exam, how to get a good verbal history that is specific, how to understand centralization, peripheralization, patterns, and how to apply the procedures correctly. But doing the procedure, side bending to the right, that's not rocket science. It's how to use it in this repeated movement testing milieu, so to speak. So he is now going to be doing slight retraction, right side bending with overpressure to that right side. If that arm for some people is so irritated they can't do that, I can have them push with the unaffected arm. Then I said if he started to feel like he wanted to do some of the sagittal motions afterwards, because sometimes people start feeling like they need some extension, he could add that back. But we saw some sign improvements with the retraction extension movements, right? But we didn't see a lot of symptom change. He wasn't coming in saying his symptoms were better, but it didn't make his symptoms worse until we did too much of it. So a little bit of it might be still beneficial. I saw him for visit 4 about 2 weeks later. He was doing the side bends more than 6 times per day. He did the overpressure and then he just stopped the overpressure and just did the side bends. His extension, he did notice now that when he extended, it was more consistent with producing that wave down his right upper extremity. It's just something he had noted, but he felt that he was better. So going on to the physical exam, better meaning for him less production of paresthesia down the upper extremity into the thumb. Shoulder still good, note in terms of strength and external rotation, no tension in sitting, very mild deviation I wrote in extension, so still a little bit there this time. No symptoms with lateral procedures, no loss with lateral procedures. So I had him do the homework to make sure the demonstration proved that he was doing it correctly. It was good. So then I looked at 3 sets of 10 of the right side bending with overpressure. So let's do more and see what happens. Mild improvement with pain in the retraction, extension, and extension. So the extension was still a little bit provocative, and when I had a retraction extension, it was still a little bit provocative. So that became like a baseline to check, because you need to have something to check. I mean, if everything's fine, then what are you even doing? So those were the physical exam baselines that were still provocative, still positive. Then I looked at holding it, so I had him go over there and hold it for 2 sets of 10 seconds. Not provocative during, no production of right neck stuff or anything in the upper extremity when he did it. No real effect afterwards. Then I did some clinician mobilizations. So I stood behind him, he was seated, I moved his neck over there, and then I used my thumb to press and encourage that joint to go into right side bending. We did several sets of 6. It decreased his deviation with the extension with decreased symptoms. So sometimes it would produce his upper arm when I did that, but not every time. So I wanted to continue with some side bending, and add a little bit of force via the hold, since obviously I wasn't there to do it at home. So retraction with the right side bending times 10, hold the last one for at least 10 seconds, and then kind of see if we could go back to the middle with retraction extension. So again, I'm making it a little bit more confusing, well, not confusing, but a little bit more complex by having 2 movements, but I did think we would need to get back to that extension. A lot of lateral symptoms present that way, where lateral symptoms or symptoms that respond to a lateral procedure is that moving in the sagittal plane, flexion extension, may have no effect, it may improve and then plateau or make them worse. You go to the side, you get a lot of improvement by going to a side movement, and then you need to finish by going back to the middle. I wanted more return to the gym so we could really test the stability or how well this could function with load. And that was it. So basically a little bit more force with the sustained right side bending, and then trying to add a smaller set of retraction extensions after that. I saw him again 2 weeks later. He commented he was over 95% better. He said that retraction, he can still feel his right shoulder consistently if he retracts, but he had returned to the gym. In terms of the physical exam, I looked at all 8 of them just to be sound. I didn't even test nerve tension and upper extremity strength that I wrote down, because it was good the last 1 to 2 visits. So as a clinician, we don't need to waste our time necessarily with things that have already been solidified as good, as negative tests. So protrusion, no problems. Flexion, no problems. Retraction, I wrote as full, but it produced right upper trap. Extension, I still put as a minimal loss, but there was no deviation, and that minimal loss might actually be his normal. I have to choose, do I think there's 0% loss or 100% loss, based on comparing him to other people his age, based on comparing him to what he moves like in other directions. But my assumption or my delineation that he had a minimal loss, that might actually be his full range of motion. So we're not going to perseverate on that. Side motions, importantly, full and pain-free. So all 4, right side bending, left side bending, right rotation, left rotation, right and left rotation, full, pain-free. His demonstration of his home program was good. I wanted to see if, okay, maybe now going back to the prone sustained retraction extension would abolish that kind of right upper trap symptom with retraction. I had him do it 2 for 30 seconds. No effect when he held that position, better retraction afterwards. And then because he had decent range of motion in this position, when I had him do it prone, I had him put his elbows on 1 inch of books, and that had no effect when he did it. No production of symptoms in the right upper extremity or the neck or the upper trap or the thumb, and afterwards retraction felt better. In this scenario, I'm asking him, retract again. Does that feel worse, better, about the same? Because there isn't much to go on in a physical exam or go off of from a physical exam that's pretty darn good and a patient that's saying I'm over 95% better. So I said, continue with the right side bending, followed by the prone sustained on 1 inch of books, at least 6 to 8 times per day until you feel like a normal person. What I tell people is, once you continue with the high frequency of the home exercise program, which is at a minimum 6 times per day, but for a lot of people, they really need that full 8 to 10 times per day every 2 hours. Once you feel like a normal person, stay at that high frequency for at least a week. I think the textbooks say to do it for a month. I know in this world, most people are not going to do that. We tend to back off on the therapy when we feel like a normal person, but especially for someone who really wants to load the joint with heavy lifting, maybe that makes it more important. I don't know. I mean, we load the joint looking at a phone for 8 hours a day too. But I tell people, once you feel like a normal person for a week, then you can decrease that frequency of the home program to a maintenance program that works for you. And I've mentioned this a lot, but the maintenance program is really tailored to what works for that patient. Do you need to do side bending of the neck every day? Do you need to just do extension every day? Do you need to do it once a week? Do you need to just make sure you're not staring down into flexion, because that tends to be provocative? The goal is not to have, I do this exercise every day or every 3 days or 3 times a day. The goal is you need to keep full range of motion of your neck into all 8 directions without pain. And whatever you need to do to keep you there, whether it's avoidance of something, avoidance of certain mechanical loads, or it's the addition of certain mechanical loads, or it's both, you need to find what works for you. My job is to help you find what works for you. And in my visits, I'm usually starting to talk about what a maintenance plan looks like early on, so that they kind of start to understand early on, oh, I might need to understand how to do this really well because I'll be doing it once a day or once a week for a long time, possibly the rest of your life. For some of these issues, especially I find in the extremity joints, unlike spinal joints, you may never have to think about this again. But I will say, for people who have spinal disorders that are mechanical in nature and can be fixed with specific mechanical movements, especially if they have had recurrences, this is not just one time, they need to kind of stay on top of this. If there's a person whose neck goes out because they got hit with a football, that is different. That doesn't kind of presuppose years of maybe dysfunction or mechanical problems. But for someone who's like, oh, my neck goes out every couple years, now it's into my shoulder blade, now it's down my arm, there's been some vulnerability there for a while. And staying on top of it by just doing what you need to do to keep your range of motion is, I believe, the best course of action. I do not believe or subscribe to the idea that it's about strengthening the muscles around there. I believe it's about making sure the mechanics of the joint are on point. And what shows us if the mechanics are on point? Number one, full painless range of motion. Full means full. It doesn't mean you can just go 75% of the way and it doesn't hurt. It means full. And so the patients I have, I really want to teach them, that's your full range of motion. Do not say in 5 years you're losing it because you're 40, or in 10 years you're losing it because you're 50. You should have that full range of motion, and it will require some effort on your part in most cases. Either means instead of sitting for an hour at your desk, 1 hour of your day, you're going to lie on your stomach and give your spine some extension. There are tricks that I'm talking about. There are ways to just change your lifestyle to keep your full range of motion. But if that joint is moving well, you have full painless range of motion, you will not have any associated weakness, you will not have any associated nerve tension. Those joints need to move well for the muscles to function well and for the nerves to have their normal extensibility that is pain-free. So this is a good example of 5 visits to fix this. Not all cases are that quick or seemingly that easy. It's become easier for me as I get more experience with repeated movement testing. But when you're seeing unilateral symptoms, just in the upper extremity on the right, for example, or just the right neck, we are seeing a lot of these patients respond with sagittal movement. So we don't jump to a lateral procedure right off the bat, but we may. And especially if someone's obviously saying, the more retraction extension I do by visit 3 or 4, now the fingers are getting worse. Well, there's your red light. There's your sign to stop and look at a lateral procedure. Could you look at flexion if extension is making the person worse? Yes, but that's not how, we're not going to flexion with a nerve root irritation because of the kind of anatomy of the neck. But again, kind of mainstream orthopedic conservative care is not looking at repeated movement testing. I think it's the most important test we have at our disposal in orthopedics. It is going to fix a specific repeated movement, is going to fix a mechanical problem that needs a specific repeated movement. If this disc has sequestered and part of that disc material was sitting on that C6 nerve root, we're not gonna be able to get it off it. Time and environment for healing would be the plan. If there is something inflammatory hitting that nerve root, repeated movement testing is not gonna fix it. Repeated movements are gonna fix mechanical problems. And most people who have orthopedic disorders or musculoskeletal disorders are mechanical problems. They're just being diagnosed incorrectly in my mind as structural problems that don't have a repeated movement solution, or inflammatory problems, even though it's not presenting truly inflammatory like if you ask the right questions, or they're being diagnosed as, oh, you have weakness, oh, you have you have muscle tightness. Those are shots in the dark in my mind. You have to collect all the verbal history, all the specific questions you need answers to. You need to do a really robust physical exam and then ask yourself, well, does this sound like a muscle lesion? Especially if there was no trauma to the muscle. Does this sound like a structural lesion? Does this sound like a mechanical problem? Most of these problems are mechanical. For more information, Robin McKenzie and Stephen May wrote 5 textbooks on mechanical diagnosis and therapy, using repeated movement testing, that is, to ascertain if a repeated movement specifically will fix it. And then there's also Treat Your Own Neck, that is geared towards the public, that will walk you through how to kind of use this system for yourself if you don't make it to a clinician or don't want to see a clinician. Please feel free to leave questions or comments. I'll do my best to answer them the best I can.